Welcome to This Week in Obstetrics and Gynecology. This week we're covering 10 notable papers spanning critical developments in maternal-fetal medicine, advances in gynecologic surgery and imaging, and new insights in reproductive endocrinology. Let's dive in. We begin with major updates in obstetric care and fetal surveillance, starting with a massive population-based study. Researchers evaluated electronic health data from over 3 million singleton births in England's National Health Service to compare 7 different fetal weight standards. They found that unadjustable one-size-fits-all growth charts, such as the Hadlock or Intergrowth 21st standards, fail to reflect the wide ethnic and demographic diversity of the modern obstetric population. For example, the rate of babies classified as small for gestational age varied dramatically from about 5.5% using the Intergrowth standard to nearly 19% using the Fetal Medicine Foundation chart. Large for gestational age rates similarly fluctuated between 5% and nearly 18%, depending on the standard applied. In contrast, the customized GROW standard, which adjusts for maternal height, weight, parity, and ethnic origin, demonstrated the most consistent and narrowest range of small for gestational age rates across different regional health boards. This study highlights that static growth charts systematically fail to identify at-risk fetuses in diverse populations, suggesting that clinicians should transition toward customized growth standards to ensure personalized and safe antenatal care. Moving from fetal growth to maternal postpartum health, a retrospective cohort study in the American Journal of Obstetrics and Gynecology investigated the long-term neurological and psychiatric consequences of ischemic placental disease. Utilizing the United States nationwide readmissions database, researchers analyzed over 17 million hospital deliveries and found that nearly 11% of patients had a diagnosis of ischemic placental disease, which includes preeclampsia, placental abruption, and fetal growth restriction. Women with ischemic placental disease experience significantly higher rates of postpartum hospitalization for neurological and psychiatric disorders within the same calendar year as delivery, with over 1,200 hospitalizations per 10,000 women compared to just 730 per 10,000 among those without the disease. The risk of these brain disorders, which included stroke, migraine, epilepsy, depression, and anxiety, increased in a dose-dependent manner with the severity of placental disease. Specifically, having a single ischemic placental disease condition increased the risk of readmission by 47%, while having all 3 conditions nearly doubled the risk. These findings suggest that the microvascular and endothelial dysfunction characteristic of ischemic placental disease serves as a critical marker of maternal brain vulnerability, underscoring the need for heightened clinical vigilance and comprehensive mental health and neurological screening in the postpartum period. Rounding out our obstetrics section, a systematic review and meta-analysis. Looking at 14 studies involving over 2,000 participants, researchers compared the risk of intra-amniotic infection between patients undergoing induction with a cervical ripening balloon and those receiving pharmacologic methods like oxytocin or prostaglandins. While the overall analysis across all studies showed similar infection rates, a critical sub-analysis restricted only to randomized controlled trials revealed that the use of a cervical ripening balloon was associated with an 84% increase in the odds of developing an intra-amniotic infection. A similar elevated risk was found when restricting the analysis to studies with a low risk of bias. These findings suggest that while mechanical ripening is a valuable tool, it may introduce a higher infectious risk when the membranes are ruptured, meaning clinicians should carefully weigh these odds and discuss them during shared decision-making for labor induction. In the field of gynecologic surgery, a long-term retrospective study in obstetrics and gynecology provides essential counseling data for patients choosing between uterine preservation and hysterectomy for apical pelvic organ prolapse. Using the TriNetX research network in the United States, researchers compared native tissue hysteropexy to hysterectomy with apical suspension in matched cohorts of women with a median follow-up of around 9 years. The study found that while hysteropexy was associated with slightly lower rates of short-term postoperative complications, such as a 22% reduction in urinary retention and a 21% reduction in urinary tract infections, it carried a significantly higher long-term risk of prolapse recurrence. Specifically, Women who underwent hysteropexy had a 77% higher risk of requiring a subsequent prolapse reoperation and a 63% higher overall retreatment rate, including pessary use, compared to those who underwent a hysterectomy. Notably, only about 3% of patients in the hysteropexy group eventually required a subsequent hysterectomy during the follow-up period. This study provides invaluable long-term data, allowing surgeons to counsel patients that preserving the uterus offers a smoother immediate recovery but carries a modestly higher risk of needing repeat treatment in the decade following surgery. To minimize surgical complications and optimize preoperative planning, a prospective diagnostic accuracy study in ultrasound in obstetrics and gynecology evaluated the utility of the transvaginal ultrasound sliding bladder sign for predicting dense adhesions. In a cohort of 128 women undergoing laparoscopic hysterectomy for benign conditions, independent assessors evaluated whether the bladder slid freely over the uterus during a preoperative ultrasound examination. The study revealed that the sliding bladder sign had an overall diagnostic accuracy of 89%, with a remarkable specificity of nearly 97%, though its sensitivity was more modest at 69%. The positive predictive value was 89%, and the positive likelihood ratio was over 21, indicating that the absence of bladder sliding is an incredibly strong predictor of bladder to uterine adhesions. Incorporating this quick, non-invasive assessment into routine preoperative ultrasound examinations allows surgeons to anticipate anterior compartment adhesions, plan their surgical approach, and improve perioperative preparedness. Also in the realm of gynecologic imaging, a Danish multicenter study, or ADNEX model, in general gynecologic settings. The study evaluated over 1,800 patients, with the vast majority examined by non-expert examiners using standardized international ovarian tumor analysis terminology. The ADNEX model demonstrated outstanding diagnostic performance, achieving an area under the curve of 0.93 when including serum CA-125 and 0.92 without it, which was significantly superior to the traditional risk of malignancy index. Crucially, the model performed exceptionally well in detecting early-stage ovarian malignancies, achieving an area under the curve of 0.90 without CA-125. At a conservative 5% risk threshold, the ADNEX model without CA-125 successfully identified over 84% of early-stage malignancies, with a specificity of nearly 82%. These findings confirm that non-expert clinicians can highly rely on the ADNEX model using standardized ultrasound terminology to guide oncology referrals, even without waiting for laboratory tumor marker results. Turning our attention to reproductive endocrinology and assisted reproductive technology, a systematic review and meta-analysis in fertility and sterility addressed the ongoing debate surrounding embryo transfer stage strategies. Analyzing 11 studies representing over 150,000 cycles, researchers compared the cumulative live birth rates of a blastocyst stage strategy, where surplus embryos are frozen at the blastocyst stage, versus a cleavage stage strategy. While the primary analysis of randomized trials suggested a borderline benefit for the blastocyst strategy, a rigorous post-hoc sensitivity analysis revealed no statistically significant difference in cumulative live birth rates between the two approaches. Similarly, observational studies showed comparable success rates. However, a subgroup analysis of trials where patients underwent fewer than 2 embryo transfers did show a 14% increase in cumulative live birth rates with the blastocyst stage strategy. This suggests that while both strategies are highly effective overall, a blastocyst stage strategy may offer a modest advantage for patients with a limited number of planned transfers. In ovarian stimulation protocols, a systematic review and meta-analysis in ultrasound in obstetrics and gynecology compared progestogen-primed ovarian stimulation, or PPOS, against traditional gonadotropin-releasing hormone analogs. Synthesizing data from 20 randomized trials involving over 4,000 women, the researchers found that compared to gonadotropin-releasing hormone antagonists, the PPOS protocol was associated with a 13% increase in the live birth rate and a higher average number of retrieved oocytes. There were no significant differences in the rates of cycle cancellation or premature luteinizing hormone surges, and no moderate or severe cases of ovarian hyperstimulation syndrome were reported in either group across 10 studies. When compared to gonadotropin-releasing hormone agonists, PPOS demonstrated equivalent efficacy and safety. These findings support PPOS as a highly effective, safe, and patient-friendly alternative to antagonist protocols, particularly in freeze-all cycles where fresh embryo transfer is not intended. Further optimizing frozen embryo transfers, a large multi-center cohort study in fertility and sterility investigated whether timing natural cycle frozen embryo transfers using endogenous progesterone measurements affects outcomes. Analyzing over 26,000 cycles in the United States, researchers compared a protocol where embryo transfer was performed exactly 2 days after serum progesterone reached 5 nanograms per milliliter or higher against true natural, modified natural, and programmed protocols. The study found that the live birth rate in the progesterone-guided group was 50%, compared to 47% in the programmed group, representing no statistically significant difference. Rates of clinical pregnancy, biochemical pregnancy, and pregnancy loss were also comparable across all endometrial preparation protocols. This timing strategy provides a highly reliable and flexible clinical alternative, allowing providers to salvage natural cycles that might otherwise be canceled due to a missed luteinizing hormone surge. Finally, as glucagon-like peptide-1 receptor agonists become increasingly common, a pharmacovigilance study in obstetrics and gynecology highlights important reproductive side effects that clinicians must be aware of. Utilizing the Food and Drug Administration Adverse Event Reporting System database through March 2026, researchers conducted a retrospective cohort study of female patients aged 12 to 55. They found that semaglutide was associated with a broad safety signal for menstrual irregularities, including heavy menstrual bleeding, intermenstrual bleeding, menstrual clots, oligomenorrhea, and anovulatory cycles. Tirzepatide also generated significant signals for intermenstrual bleeding and menstrual clots, while liraglutide showed no such associations. These findings suggest that these medications have complex, pleiotropic effects on menstrual physiology, and clinicians should actively include menstrual health counseling when prescribing or managing patients on these agents. If you only have time for one paper this week, make it the massive cohort study from the BMJ evaluating fetal growth charts. This study of over 3 million births demonstrates that one-size-fits-all growth charts fail to account for maternal diversity, highlighting an urgent clinical need to transition to customized growth standards to prevent missing at-risk fetuses. Here are the key takeaways from this week in obstetrics and gynecology. First, unadjustable fetal growth charts are highly unreliable across diverse populations, and transitioning to customized growth standards like GROW is essential to accurately identify small and large for gestational age fetuses. Second, ischemic placental disease is a strong sentinel marker for maternal brain vulnerability, significantly increasing the risk of postpartum readmission for both neurological and psychiatric disorders within the year following delivery. Third, while native tissue hysteropexy for apical prolapse offers a lower risk of short-term postoperative urinary complications compared to hysterectomy, it carries a 77% higher risk of long-term prolapse reoperation. Fourth, the non-invasive ultrasound sliding bladder sign is highly specific and accurate for predicting dense bladder-to-uterine adhesions, allowing for improved preoperative planning. Finally, semaglutide and tirzepatide are associated with significant signals for menstrual irregularities, including heavy bleeding and intermenstrual spotting, which must be incorporated into patient counseling. That's your roundup for this week in obstetrics and gynecology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.